Good evening, ladies and gentlemen. Thank you for all arriving well on time. So many of you were here before, either because this is very interesting or you're interested in all the food and drinks, but very happy to see such a full house. So a warm welcome to everyone here at the IFPMA's flagship event at the 71st World Health Assembly. And the theme is Continuing Progress in Global Health, Working Together for the Future. Now, we are celebrating our 50th anniversary as an industry association. And during that time, healthcare has come a long way in those 50 years. Now, we want to stress that none of these developments would have happened without a huge range of individuals and organizations all working together from different angles, but with the shared goal of health progress. But in this ever closer globalized world, the need for coordinated activities and partnerships to enhance health in the future is more important than ever. So with this in mind, I want to stress three main points that we would like to get out of this meeting today and why we're here. First, as I said, it is to celebrate our 50th anniversary. And at our 50th anniversary, we will be launching today a report, and our Director General Thomas Cueni will be introducing this report, and we will have a short video session that goes with that. Second, it is an opportunity to hear the thoughts, the ideas from our guest speakers who represent the whole cross-section of the community of people that are working in this public health area. And we very much appreciate their time in coming here today. Third, and probably most importantly, it is an opportunity for us to engage with the whole global health community on the vital issue, the collaboration that we need to embrace in order to deliver continued global health progress and to provide treatment to patients wherever they be. As I said, we have indeed come a long way, and as Thomas often wishes to stress, there is still much more to be done, and we are here to do that. Now, very quickly, I want to just run through the schedule of today. It should come up on the screen. If it doesn't, okay, I'll run through it. We're going to have two guest speakers. First will be Brett Giroir, the Assistant Secretary for Health at the U.S. Department of Health and Human Services. We will then have Thomas Cueni, who will present our report, and then Dame Sally Davies, who I think doesn't need any introduction whatsoever. And then we will open up from then to our panel discussion, which will be moderated by Ilona. So on that basis, and no further ado, I would like to welcome Brett Giroir, the Assistant Secretary for Health at the U.S. Department of Health and Human Services. And I would like to stress a physician, a scientist, an innovator, and prior to taking on his current role in the U.S. federal government, led a medical school, ran a biotech startup, and served in the U.S. military. So I'll definitely be listening to what you're saying. Thank you very much.
I think the first thing I'm going to do is move these glasses so they don't wind up. Good. So thank you very much for inviting me. It really is an honor to be here at all, but it's much more of an honor to be here to celebrate your 50th anniversary. I know what these milestones mean, and certainly this is a very important one for you. I'm also very thankful that you had me speak before Dame Sally instead of after Dame Sally. That's a really good thing in terms of the lineup, because I know she'll have many important things to say that everyone will be listening to. Public health was very different 50 years ago. It's hard to even categorize some of the main issues that we've gone through. We've eradicated smallpox, mapped the human genome, seen the rise of HIV/AIDS, and also the emergence of effective therapies that are controlling this horrible disease. Even when I was in medical school, if you told me we'd have a pill to cure hepatitis C, would have almost been unimaginable. We finally figured out how to unleash the human immune system against cancer. Cancers that would have been a death sentence only a few years ago are now curable without the infusions of chemotherapy, poisons that rob patients of so much of their vitality and often their life. Francis Collins and I have a friendly bet for a beer. He says sickle cell will be cured in 5 years, and I certainly hope that is. It's certainly one of my issues in the Department of Health and Human Services. But I also tell him, we have many new challenges to public health, and in fact, we've caused some of them by some of our innovations. Burdens of non-communicable diseases are now draining lives and resources from countries throughout the spectrum of the development process. Certainly in the United States, 9 out of the 10 leading causes of death are from non-communicable diseases, the first 2 being cardiovascular disease and cancer. Only influenza and pneumonia are in the top 10. They're actually at number 8, and they're an order of magnitude less than cardiovascular disease or cancer. Secretary Azar a few weeks ago assigned me the opioids lead for the Department of Health and Human Services. By creating effective pain medications that often, when used appropriately, saved patients from excruciating pain and certainly allowed them to die in dignity, we've created a substance abuse nightmare within the United States, and I've learned today in Canada as well. Last year, we lost 68,000 people in the United States to overdoses of drugs, 68,000. 46,000 of them were due to opioid overdoses, and that number's going up. It's rising at a 12, 13, even 16% year-over-year rate, and I'm spending much of my time doing that. We have created, to a great deal, the threat of antimicrobial resistance in organisms that we have difficulty, if not the impossibility of treating. I'm a pediatric critical care physician. When I first started practicing, I worried about this in chronically debilitated, chronically instrumented patients. 10 years into my practice, 30% of my patients coming in an outpatient, naive patient, had staph and pneumococcus that were resistant, causing me, instead of using penicillin or something simple, using multiple antibiotics, including vancomycin, just to assure that a patient with a severe illness were treated. Our global connectivity and environmental disruptions have made risks of influenza pandemics and the emergence of new diseases more prominent. And I was at DARPA for 4 years. I ran the science office at DARPA, and I think I would be remiss to say that recombinant DNA and synthetic biology at least raise the possibilities for those who want to cause harm to have an even greater ability to do so. So we have great successes in public health, but I think we're only beginning with some of our challenges, and we're creating new challenges. Now, in my office, we're always going to start with prevention. I think prevention is always better than the cure. We may be able to make amputations for diabetes much more efficient, save a day of hospitalization, but we really need to move that curve all the way to the beginning, to effective diabetes care, and in the first part, decreasing obesity, increasing activity. But to create new medicine vaccines, we're going to have to be partners, as we have always been. Basic research, often sponsored by governments, in the NIH budget, over $37 billion this year. Early proof of concept, often done by startups and biotech, funded by angels or small venture capital. And product optimization in large clinical trials, often done by partners such as yourself and other member organizations of this organization. I was a fellow in 1993. We had a meningococcal outbreak. I didn't have an answer. I buried 5 kids a month in my ICU with meningococcal disease at the time. I turned to biopharmaceutical. I must admit I was pretty much chastised and almost ridiculed out of the academic medical center for wanting to partner with pharma. But pharma had the only thing that I could help my children who were dying in the unit or sending home with 2 limbs, 4 limbs amputated. So I've long been a good partner of pharmaceutical industry and know that we all have to stay within our boundaries, within our ethical guidelines, but we have to do this together. I'm also happy to say that we're going to try to do some things aside from partnering. If you're in the United States, we have a new common rule. It's the first time the common rule has been revised in 30 years. Our office has spent an enormous amount of effort doing that. There's been a notice of proposed rulemaking that says we're going to delay it till January, although we're implementing many of the factors right now. But that's going to immensely enable research to go more quickly, more expeditiously. How nice would it be when you have a 100-center trial in the United States to have a single IRB instead of 100 IRBs to go through? Just that one regulatory step is going to be able to accelerate our partnership while providing extra patient safeguards. And I'm absolutely convinced that the common rule will better protect patients, but it will also facilitate research. I also wanted to note that your anniversary is not the only one this year, and I think we should also celebrate one of the best-known U.S. global health incentives, PEPFAR, which was signed into law by President George W. Bush on May 27th, 2003, almost 15 years ago exactly. With strong bipartisan support, and it still has strong bipartisan support, the U.S. government has invested nearly $75 billion in the global HIV/AIDS response. And you know what? I could think of no better investment in the history of our country than the investment in PEPFAR. Over the past 15 years, PEPFAR has transformed the global HIV response and has saved over 13 million lives. Pretty remarkable. In collaboration with our bilateral and multilateral partners, 13 high HIV burden countries are now on the verge of epidemic control by 2020. But in my own job, I look inward since we plan the national HIV strategy in the United States. Before I came into this job, when I was researching it, it was almost it was remarkable to me that in the United States we still have 40,000 new cases of HIV a year. I know that the new director of the CDC and myself want to make a commitment to do our best effort to turn that to 0. There is no reason why a preventable disease should not be prevented, particularly in the United States. If we can't do it in the United States, how could we expect other countries to do it? So we just need to do that. Of course, PEPFAR's contributions extend beyond the sphere of HIV. And you've heard this story many, many times in this meeting, that it's all about building the infrastructure and the capability and not being siloed disease to disease to disease. HIV interacts with TB, diabetes interacts with TB, and everything is all as one. It's primary care. Focus on the patient, not on the disease. They're not a disease accompanied by a human. They're a human burdened by these diseases. So I want to just end with a couple of things that are important to understand from our point of view. The U.S. is in favor of both push and pull incentives and market entry rewards, and I think that's important. We do push incentives reasonably well with the work the NIH is doing, but also with novel partnerships like CARB-X, a private-public partnership to aim at promoting innovation in the bacterial and the antibacterial product development space. At DARPA, this is what we did all the time for defense, and we did it for biology. We put government money in to de-risk novel innovations that one day can turn into a great breakthrough. It's a very difficult job at DARPA because they tell you when you come in, if you don't invent the internet, you get a B-. No pressure. We're also very involved in the development of strong pull incentives, which are now needed, a market system that rewards with substantial payment new products that are truly innovative and make a difference. And I think we are really engaging with our current secretary with an intelligent dialogue of how do we balance innovation with affordability. You can't have one or the other. We have to have both because we haven't solved the public health crises. We're just entering into a new era. So again, I want to thank you for this opportunity to share a few thoughts early on. This is my first WHA. It's my last talk at WHA. I hope it's not the last time we work together with each other. I've been in my office 3 months. It's been the best ride I've ever had, and I really look forward to working with partners such as you to really make a difference. That's why we're here. Make a difference, make a contribution. In the end, hopefully people are better off for it. Thank you very much.
It's movie time, isn't it?
Patients get it. They know medicines just don't materialize out of thin air. Somebody who's invested and understands the disease process has to spend some time in having them med.
Any development in healthcare, treatment or cure takes multiple partners to get it from the basic science to clinical delivery to patients.
Their job is producing the drugs that keep people alive. Our job is making sure they get to the kids, and between us, that's a good partnership.
All the results say that it is working.
That period of exuberance early on in the development of a new, novel, cutting-edge technology, it's very easy to get caught up into that. The reality is this is still science, and these are still experiments, and we are still learning.
Cervical cancer is a problem in Rwanda because it's a silent killer.
It's a virus that attacks the cervix and...
They don't feel that they have a cancer, and most of the time, when they come, it's too late.
I grew up in the suburbs of Boston, and in the fall, I think November 1950, I contracted paralytic polio. I was in the hospital for almost 5 months at that time. The world panicked in those years. During the summer, don't go in your swimming pools, start school a week late.
In 1988, we estimate that there were about 350,000 children each year who developed paralytic polio. Today, the count is 52 children in the world. We have an army of 20 million frontline vaccinators who work in their neighborhoods to deliver doses of vaccine to their children and the children of their neighborhood.
Back in 1988, the only thing that I could think of is, I'm going to be dead in 6 months.
At first, it was very difficult to see how in the world we were going to solve this problem.
The medication that they had at the time was even worse than the disease itself.
Now we're at a one pill, once a day treatment for patients.
Almost every house in Qatar, they have diabetes.
I know that there is 2 types, but I don't know the difference between them.
If you do exercise, physical activity, and eat healthy food, you can avoid having diabetes type 2. The aim of Action on Diabetes is how can we help the Qatari people delay their complications, a healthy diet, give them some information about diabetes.
It's something that's always present. You're always thinking about it.
What if my cancer comes back?
I've been working on this therapy for 5 years now, and we're getting ready to go to the clinic.
My son definitely keeps me fighting. I want to be there for him when he needs me.
That's what motivates me. I want to see patients have gray hair.
As you can see, we celebrate a birthday. IFPMA turns 50 this year. Actually, a few weeks after the French students stormed the barricades in France, and we had a hot May 1968. Industry leaders got together and founded IFPMA. We have taken the opportunity to come together and look back, putting together a report on 50 years global health progress. But we also want to look forward to the challenges and opportunities for the next 50 years, because we don't want to get a pat on our back. We really want to look at where did we succeed, where are challenges, where did we fail. The report is not a new Encyclopedia Britannica, far from it. We looked at 7 disease areas, comparing where we were then with where we are now, some of the challenges faced along the way, and also talk about unfinished business for the future. It is common nowadays, actually, if you ask people whether the world is better today than it was 50 years ago, many will say far worse. Crisis in terms of health, Ebola, Zika, Lassa fever, health situation deteriorating in conflict countries such as Yemen, Syria, or regions of Africa. But one of the reasons, of course, is I'm a former journalist. Bad news sells. Good news is a hard sell if you have to make money from selling a newspaper. Truth of the matter is we have made tremendous progress over the last 50 years. When you look at 1948, not 1968, when WHO was founded, life expectancy globally was 47 years. Now it's 72 years. People in general are healthier than ever before, can expect to live longer and in better quality of life. We have seen the eradication of disease. The Admiral mentioned it. Smallpox, actually, in 1948 was infecting 50 million people, eradicated. We have made huge progress in not just treating but curing some cancers. Childhood leukemia, for instance, or some forms of breast cancer. Huge progress in vaccines. Health benefits individuals, communities, and nations. Often we talk about the cost of healthcare, but not the cost of unhealthy people, the burden of disease. 3 things have made this change possible. And first and foremost, not biomedical research. First and foremost, clean water and sanitation. Second, transformative innovation in R&D. And third, collaborative partnerships between players in global health. The global health ecosystem is united by serving patients. They need to be in the center. And we also want to recognize the people behind the headlines, the researchers, health workers who have overcome huge odds to achieve this progress. The next few minutes, I want to zoom in on just 2 disease areas. Deliberately picked 2, which actually in the political context quite often are controversial, namely hepatitis C and HIV/AIDS. Hepatitis C, in my view, is the story of true innovation. Actually, it's the story of disruptive innovation at its best, because it caught people by surprise. It was a challenge for budget makers, for health systems to cope with this disruptive innovation. It went, when you look at the innovation, going from the identification of disease to a highly effective cure in 25 years. Hep C was first identified in 1989 by biotech researchers working together with the US CDC. Prior to this, its existence was known but not understood. The first cure of Hep C was developed back in 1991, but the cure rate was about 6%, going up 5 years ago to 40%, but with often severe side effects. Today, new antivirals, hepatitis C has a 94 to 96% cure rate in 12 weeks. And that's amazing. And innovation has not stopped. There are more than 70 Hep C products in the pipeline. HIV/AIDS, it has been 36 years since the world was first introduced to the terms AIDS, and since then it has grown into one of the world's worst pandemics. Fear of HIV was huge in the 1980s, even in the early 1990s. The first antiretroviral drugs were produced in the mid-1980s, but their efficacy was limited. In 1990, a patient diagnosed with HIV/AIDS would be expected to live for a few months. In me, HIV/AIDS brings up a few personal memories, because I was involved as secretary of a global roundtable of pharmaceutical industry in the margins with Roy Vagelos when he came to a meeting and said to his fellow CEOs, we need to get our act together, and we work together in a new way, and we need to collaborate. And that was the beginning of the launch of the collaborative consortium to speed up the development of combination treatment by exchanging molecules and test them as combination drugs in early development stage. This was really the start of making HIV/AIDS from a deadly disease into a chronic disease. Skip forward today, and an HIV-positive person receiving modern ARV treatment can expect to live a normal lifespan. Actually, I've been told by one of the Swiss specialists, slightly above average because he works normally in a perfect managed care environment, where his hypertension, his diabetes is checked regularly, and if they are compliant, actually they do well. HIV/AIDS also brings up memories for me because of the infamous South African lawsuit. The industry thought of suing Nelson Mandela. I was not involved, I'm happy to say, in launching that lawsuit. I was part of the exit team, a small group of industry colleagues negotiating the way out with the South African government, mediated by Kofi Annan. At that time, and the Admiral mentioned PEPFAR, created in 2003. Actually, in early 2000s, there were about 4,000 people in sub-Saharan Africa on ARV treatment. Today, more than 20 million in developing countries. We have come a long way since 2002 when Gro Brundtland, Kofi Annan, and industry leaders signed the joint statement of intent on accelerating access to effective treatment. Now, let's look at the future. What does it mean? We have made amazing progress, but we also have a lot to safeguard the progress which has been made, and we need to do better and we need to do faster if we want to meet the ambitious SDGs. I just mentioned a few of them. Health security is top of the mind. We had today a lunchtime event on the centenary of 100 years Spanish flu. Epidemics pose significant risks worldwide, from known pandemics such as HIV/AIDS and Ebola to future threats. Antimicrobial resistance, and I'm sure that Dame Sally will talk about this too, is an increasing threat too. Diseases become resistant, reversing gains made in the last 50 years. We really need to ensure and act in partnership to make sure that the global health community is aligned and ready to do what is needed. We have demographics, and we are likely to see change dramatically. Aging societies, migration, urbanization, population growth, climate change, and all of them put stress on health systems. We also have non-communicable disease. Many of us live a pretty unhealthy lifestyle. Too much time in meeting rooms, too little time walking to talk. Therefore, I want to conclude with what next. Dr. Tedros on Monday in his speech, and I quote, said, "We are engaging with the private sector, who will be a crucial partner in achieving health for all." The framework of engagement with non-state actors, which was adopted last year, provides a guardrails for the engagement, provides a framework for the engagement, and FENSA, he said, is not a fence. I was really pleased to hear that, and he continued, "We must use whatever partnerships are open to us in whatever way we can to achieve our goal. We have to believe in partnership. That's the only way." I agree with that statement, and Dr. Tedros has my full support. But above all, and I'm personally deeply aware and conscious that we, and we means the industry, also need to do more, and we need to do better to live up to societal expectations. In tackling the healthcare challenges of the developing world, we need to leave our own comfort zone and collaborate with others, be it in engaging on health systems reform or in partnerships to bring innovative medicines to millions of more people in resource-constrained settings. We strongly support the principle of universal health coverage, and I'm sure that Tim Evans will say something about that in the panel, because we have a problem in terms of bringing our medicines to people if almost 2/3 of the world population have to pay out of pocket for their medicine. We have come a long way in the past 50 years, and we want to make sure that global health progress happens in the best possible way for the next 50 years. That's why we are hosting this conversation today here in the global health capital, Geneva. We are very excited to have so many different stakeholders among us. We really look forward to an animated, engaged debate and lively dialogue so that we really can continue to make further progress over the next 50 years. I look forward to and invite the comments of our audience and partners here tonight. And with this, I really want, and it is my great pleasure to introduce Dame Sally Davies, our second keynote speaker following Admiral Giroir. Dame Sally is Chief Medical Officer for England and Chief Medical Advisor to the UK government, a job, Chief Medical Officer, which is actually not just 15 years old like PEPFAR, but 160 years old, which I think is probably the longest-standing Chief Medical Officer in the world. Now, Dame Sally, as Greg said, doesn't need much introduction. She is a champion on many health issues in the world, and I've come to admire her leadership, in particular in the area of antimicrobial resistance, where she serves as a co-convener of the UN Interagency Coordination Group. Please join me in welcoming Dame Sally on the stage.
Thank you very much, Thomas. It's a great honor to be here, and it's a great report. So imagine a world without this industry. It would be a sad world with early deaths. We have made massive progress in global health over the last 50 years, and I think the report touches on many of them. Reduction and eradication of epidemic diseases through vaccination. I remember as a young doctor, I trained first as a pediatrician, then as a hematologist, and I'm a sickle cell expert, so I hope Collins is right that it'll be cured in 5 years. But I remember seeing 2 children die of measles, and that was a dreadful tragedy. We don't have to have that any longer. We've improved our international preparedness and response to global health emergencies. We saw the word Ebola there. Merck's vaccine was deployed on Monday, and there's another vaccine there that J&J have been testing that should come into practice and use pretty soon. That is impressive, and it's life-saving, let alone our understanding of how to use personal protective equipment and everything else. Think about the declines in death from cardiovascular disease, and I don't want to forget cancer, that for many has become a chronic disease, or the great things that come with transplantation, from simple things like corneas to bone marrow transplants. I am very friendly with a family where the daughter has cystic fibrosis. She has had 2 lung transplants. The life it has given her and her family is amazing. It would not be possible without the pharmaceutical industry. So I was struck by the report, and I thought I'd pick up 3 big issues from it that have already been mentioned. The importance of partnerships. And I think they underpin what we've seen as progress in the last 50 years and helped us develop better outcomes. And we can talk about partnerships with academia, who often find a pathway, partnerships with the caring professions who prescribe the treatments, but then actually partnerships with patients who take them. But I was also thinking about product development partnerships. So we've got great product development pipelines for drugs, vaccines, diagnostic tests in global health. Think about the TB Alliance and the Drugs for Neglected Diseases initiatives, vital in addressing the global disease burden and addressing issues that matter in the low and middle income countries and that will continue to matter. I want to pick up as a second issue access to drugs and treatment. We know that at the moment more people die of lack of access to antibiotics than die of drug-resistant infections, and that this is impacting particularly in low-income countries. So we've really got to improve access and think about how generics companies are playing their role in making sure that drugs are available, more affordable, and easier to access. We need resilient systems, and the generic systems is part of helping that. But actually, some of the big pharma have also supported local production, IP transfer, and innovative manufacturing in the South. That is partnership to help the community. And we can think, under the third issue I wanted to pick up of social responsibility, about tiered pricing as being a really important issue. And the HIV example is, of course, the original one, but now with market making and things like vaccine purchasing, we're seeing tiered pricing that works. The final thing I wanted to pick up as an issue that is there in the report is social responsibility. We know that we have to balance profit with corporate responsibility. And I think we're talking here about fairness, and the tiered pricing and some of these market-making mechanisms that supporting local market production and things are all major contributions to this fairness issue. But we also have to be honest that we haven't cracked this. We haven't found a model to pull through for some diseases where they don't impact particularly in the rich countries, and TB's example I want to pull out there. So let me use antimicrobial resistance as an example to work through some of this. I do believe the industry has a social responsibility. In stewardship, we've got 28 antibiotics in late stages of clinical development, but only 2 of those report through the Access to Medicines Index that they've got both access and stewardship plans in place so that they can prolong the life of those antimicrobials and make sure they save the most lives. There's an approach to decoupling antibiotic sales volumes from sales agents' bonuses, and GSK and Shionogi are leading the way. Novartis and Pfizer are starting to do this. But can we get other companies to do the same? And then a third area of this social responsibility, when we look at it, is the production of antibiotics and their release into the environment, either through manufacturing or manufacturing of the APIs. And in a study, 8 of 18 companies looked at this, and they have set discharge limits for antibiotics. So this is beginning to happen, but it's interesting that no company is yet publishing its discharge levels. So set that on one side. We're making progress. We've got a terrific more to do. And think about our successes. And the example I was going to use was, of course, HIV. But let me just reflect on cardiovascular disease. When I came into medicine, one of my early jobs was on a coronary heart ward, coronary disease ward, and we got patients in with heart attacks all the time. And we used antiarrhythmics, we used pacing, but a lot of them died, and we took a long time to rehabilitate them. Now, our death rate from heart attacks is much, much lower. And it's because we've controlled hypertension. That needs both checking by the health system whether people have it, but it needs effective drugs. And we have a variety of drugs that work phenomenally well. Another risk factor is cholesterol. And we have the best-selling statins to deal with that. And for those minority where the statins don't work, we now have anti-PCSK9 antibodies, which are showing not only that you can control cholesterol, but you can actually leach it out of the arteries so that people get better and better arteries in their hearts. Meanwhile, when people do have angina or heart attacks, if their vessels are getting blocked, our wonderful cardiologists go in under ultrasound guidance and put in a little stent. We would have none of that without our industry and the partnership of developing these things and getting them into practice, and then the partnership with the patients that actually choose to adhere to these treatments and accept them. And don't forget the ones who did the original research to show it works. So I just want to end, not surprisingly, with the future challenge, and that of tackling antimicrobial resistance. Because if we look forward 50 years, that has to be one of the issues we've got to deal with. Because it's an escalating threat, because if we don't get it right, we will lose modern medicine. Antibiotics, antimicrobials underpin so much of modern medicine, whether it's cancer care, whether it's everyday infections, or operations, they underpin it. And I would hate to lose any of those to our armamentarium. But it's also that antimicrobial resistance and the drug-resistant infections are hugely challenging, multi-sector. Animals, fish, the food chain, agriculture, let alone the humans. And, as I keep saying to my politicians, we may live on an island, but when it comes to illness and diseases that are infectious, including drug-resistant infections, we are not an island. Our travel and globalization brings these things from one country to another, and we have to work together. You saw the picture of the Sustainable Development Goals. I could show you the wonderful work of the charity REACT about how if we don't sort AMR, then we will not deliver the SDGs. We had a resolution at the high-level meeting in 2016 of the UN General Assembly, and member states signed up to delivering a roadmap, signed up to making a difference. But we're still all grappling with a number of issues. How do we keep that political commitment for something that is so multi-sectoral? Where are the leaders and champions across the sectors and countries so that we can really spread the movement? We've got the IACG sending, this time next year, recommendations to the UN Secretary General. But what will happen after that? Can we strengthen the global governance structure and bring in all the partners, bring in industry who are part of the solution? We cannot sort it without. And that's not just pharma and biotech and the vaccines industry. That's actually farming and aquaculture and the food chain. We need industry and civil society in this discussion properly. But then we've actually got to find innovative funding mechanisms to stimulate the research and development and ways to ensure access to quality assured medicines for all of them to get to them who need them. So I would ask industry, what is your commitment to avoid AMR causing the catastrophic impact that it threatens over the next 50 years? And as I finish and wish IFPMA happy birthday, I want us also to celebrate two other birthdays, the WHO's 70th and the National Health Service's 70th. And what I'm hoping for outside is jelly. Because my father, who was an academic theologian, said you couldn't have a party without jelly. I think that demonstrates my age, but I want jelly to celebrate your 50th birthday. Happy birthday and thank you.
I'm not sure, I'm going to have to work on the jelly. I'm not sure how many people here realize what jelly is. It's very particular, it's not jam. Okay. I am going to hand over now to Ilona Kickbusch, and I ask the distinguished panel to join Ilona. Just for understanding, we're going to have the panel discussion now, if you would like to join. And looking if we have time after the panel discussion, we will have a short period of time for questions and answers. I'll just read out our distinguished guests. Mariangela Simão, Assistant Director General for Drug Access, Vaccines and Pharmaceuticals at WHO. I'm sure very well known to many of you here. Delighted to have Joseph Mwangi, who's the Head of Division of Non-Communicable Diseases at the Kenyan Ministry of Health. Delese, Darko, Chief Executive Officer of the Food and Drug Authority of Ghana. Evans, Senior Director of Health, Nutrition and Population at the World Bank Group. And last but not least, Dain, Chief Executive Officer of the NCD Alliance. And now, hand over.
Thank you very much. Good evening, ladies and gentlemen. I'm delighted to be here and delighted to have such an extraordinary panel. We've already heard some of the issues at stake and some of the challenges we will have to tackle if we want to move forward, and move forward perhaps in a better way and more rapidly. I was actually reading some of the material, and I understand that Thomas Cueni at one point says, we need to do better, go further, go faster. And that was not in relation to him participating in the Sunday event, but in relation to the challenge that he also poses to his industry. And maybe when we have discussions later, we can have some feedback also from the industry to the points that the colleagues here will put forward. We will discuss in a broader way about global health challenges, but of course related to the role of the pharmaceutical industry, but also to the private sector more generally. And we have some guidance, we have some goals that we need to live up to. We have already mentioned the Sustainable Development Goals, and the Sustainable Development Goals are an expression of what has been termed social responsibility. Social responsibility of everyone in order that we not just have a better world, one probably hearing Dame Sally would say that we can save our world, that the next generations can actually live on this planet if you look at some of the developments right now. Today, another guidepost was adopted, the 13th General Program of Work of the WHO, and we will come back to that, particularly also its focus, just as with the SDG 3 on universal health coverage. And we've already seen over the last years that this has started to transform how international organizations act, but also how civil society advocates, how things are financed, and how countries pick it up. And even more importantly, we can see that regional agencies are much more active also in the health arena, and we will hear about that. So first of all, I'd like to ask Mariangela Simão, interpret your Director General to us. He said, we heard, he said, Fenza is not a fence. What does that mean in your everyday life? What does that mean as you have to deal not only with the pharmaceutical industry, Thomas comes and visits you, but also, I understand, earlier today you had a meeting with civil society. So there are many stakeholders out there that you, from your position as an Assistant Director General in WHO, need to work with, and your guide posts, in a way, are this agreement that member states have found, FENSA. How do you deal with that, and what do you ask of those people that you want to work with?
That's several questions in one question. First, about the boss. I think the Dr. Tedros, who will be 1 year now elected, he combines several qualities that are very useful in the position he is right now, because he understands the country level, and it's not from the UN perspective. Having been a .gov person, he been a Minister of Health for many years and a Minister of Foreign Relations. He knows what it is to have to take decisions, and he knows a lot about country ownership. And I think very much of what the global strategy, the global program of work right now, it's concentrated on country impact, and that reflects a lot of his leadership. Now on the partnership and defense mechanism, I think that WHO is a strange creature, right? In a way, because WHO is a UN organization, but it's a member state organization. So people many times separate what you have as the secretariat, understand WHO as the secretariat, but the secretariat is run by the member state mechanisms. And I think as a lot of the WHO work relies on this, the normative role, it's very important that to separate and to have a clear vision what could constitute conflict of interest, and I think that's what the FENSA was established for, and what actually constitute fruitful partnerships on global health, in global health. So I think there's a balance there that's probably we're not there yet, but we need to take the different positions into account. I don't know if I answered what you...
Can I follow up a bit just once? If we say industry has a social responsibility.
Come again?
If we say industry has a social responsibility, how would you explain that to somebody, a young medical student who says to you, what does it mean industry has a social responsibility?
We're talking about health industries.
Yes.
Right? Yeah. Yeah. But,
they're very broad.
Yeah, but I'm going to speak from that perspective, because I truly believe that when we're talking about health-related products and those who produce health-related products that are actually to cure diseases or prevent diseases, there's something more than a commercial enterprise behind it, right? Because you're producing, like the hepatitis C is a global good. Something that cures diseases is something that brings hope of, or I heard today about the biologicals and the cancer medicines that are coming. But then I think the social responsibility comes together with that innovation actually has to have access considered into the innovation. It can't only be about providing a chance of life for the fewer people who can actually pay the high prices of that. So we need to have a balance, and I think we haven't reached that yet globally. I think the hepatitis C was a divider in the world. The issue of affordability and access turned, from being a middle-income country problems or a low-income country problem to becoming more of a global problem when even developed countries, rich countries, could not afford a public health policy that paid for that type of medicine. So we need to have a more balanced type of a global agreement around this that we haven't reached yet. And that's where the partnership and the open conversations and the discussions at the World Health Assembly may help.
Thank you. Katie, if I could turn to you, you've said very frequently that the NCD Alliance, in terms of advocacy, in terms of moving forward, needs to be a movement of people and also of patients. And you've increasingly given it a patient face also. What do patients expect from the industry? What is their understanding of social responsibility? What do you advocate for?
So in the NCD space, I mean, we've been talking about the fact that, you know, millions of people are living with diabetes around the world, cancer, cardiovascular disease, but actually, increasingly, I think we should actually be talking about the numbers in terms of billions, because if you actually add it up, it's essentially pretty much half of the world's population that are affected in some way by non-communicable diseases, including...
Can I ask who in this audience is affected by non-communicable disease? Could you raise your hands? I don't believe it. There must be more.
With families.
Okay, let's
yeah,
say who's
families.
affected personally with a disease? A good point. Second, who's affected because of their families? Excellent. Thank you, Katie. Please continue.
So in terms of the scale of the problem, it's obviously huge, and it's growing around the world. And I think during these weeks at the World Health Assembly and at other UN meetings, we can feel like there's a lot of progress going on in NCDs. We can all pat ourselves on the back and say, fantastic, there's 30 NCD side events during this week, for example. NCDs are finally getting the limelight. But actually what we see in terms of at the country level and in the community level, we've still got a very, very long way to go. It's clear that there's this real implementation deficit at the country level. And in terms of access, you know, around a quarter of countries even have the basic NCD services that's needed in terms of health systems. And 80% of the world's population don't have access to things like pain relief. So in terms of the challenge of access, in terms of availability of treatment, services, health systems that actually respond to people, we're far off the mark. But in terms of what actually people living with NCDs and those affected most want, it's really the essential right to access the services that they need. It's having the medicines at their local health facility that they can reach in a relatively easy fashion, rather than having to spend days traveling to health services and the cost that is in terms of families. It's also the fact that in terms of many low middle-income countries, as was mentioned previously, many people are still paying out of pocket for the treatment and for the medicines that they need for the conditions that they're living with. So it's really about ensuring that people have access to essential services, that they're living in human dignity and they have the rights that they deserve, but also having the support networks around them as well. And that's where chronic diseases is quite often a little bit different from some of the others, because these conditions are often, you know, lifelong. Take diabetes, for example. You need a really strong support network around you to ensure that you're adhering to your drug treatment. And in many places, that's just not there. And so recently in the NCD Alliance, we've kind of really begun to shift what we do in terms of our advocacy and the narrative that we're using, really drawing upon the HIV/AIDS experience, even though NCDs are very different, because we're talking about so many different conditions and so many risk factors. But what we're doing is really putting people and stories and the person living with at front and center of the response, because unless you do that, and unless you actually have a health system that is responding and treating people at the center, we're not going to be seeing the progress that we want.
Thank you. Dr. Mwangi, how does that play out really at the country level? You're also involved in a number of ways, also in a series of pilot projects around NCDs. So this combination that we've heard, it's all very well talking about the access to drugs, but we need the system around it, we need the affordability, we need a variety of forms of access. So could you explain to us how you've tried to turn that into reality in your country and with specific initiatives?
Okay, thanks, Ilona. And I must start by wishing a happy birthday to IFPMA, Thomas and team. Thank you so much for having us here. It's been an interesting time, this 71st World Health Assembly. Allow me to just take one step back and talk about the event that happened, the walk the talk. During that time, I was with some of my bosses, my minister and my ambassador here. And as we were talking, I looked at them and I hoped that they would understand what I mean, because the walk the talk, I took it both literally. Yes, we need to walk and do, but there is also something that requires governments to walk the talk in terms of improving domestic financing for NCDs. The speakers that have talked before me here have taken us a journey of 50 years. And during his talk, it was amazing how much laden the talk of the DG was very topical in terms of the changing dynamics in global health. He talked about what you've just said here. He started by saying health should be the currency of development, a very strategic positioning of health within the SDG. He also talked about that WHO is not at any threat with the many, many other organizations. And then what she's just talked about here about FENSA. And when I look at that and then bring it back home, I think the 50 years that Africa and Kenya has taken, we have also seen tremendous change from infectious diseases to now the double burden of disease and the triple burden of disease if we put injuries there. And I think on the ground, the ground is ripe, but only with talk. We need to move it beyond the talk. I lead a division where we know the problem. Katie and I have made enough noise over the last few years. And now NCDs, yes, is at the top of the policy agenda. But it's not top of the budgeting agenda. It is still at the bottom. And we have the opportunities. I don't know what will come out of this 71st WHA. I don't know what will come out of the 2018 UNGA meeting. So we are still at the foothill of just talking in terms of turning around the NCD agenda. As I listened to the submission from the US and the UK, it was interesting to reflect back home. You know, a child who has had 2 lung transplants, oh my, that's unheard of in Nairobi, even one of those transplants. That sickle cell would be treated in the next 5 years. Oh my sickle cell patients down there have no even access to some of the archaic drugs. So the SDG spirit was of not leaving anybody behind. And as we go ahead, we probably would start looking at the spirit of the SDG was shared prosperity. And there is no prosperity shared when probably half of the globe is going through issues of access. So I think the debate for the next 50 years, if you look at the 50 years that Thomas has described, progress was defined by how much disease we treated or how much innovations and drugs we brought to treat a particular disease. But I think going forth, the next 50 years will be of how much health have you brought, so that the prototype is no longer an illness model to a wellness model. And I think that debate is one that I would be happy to see back home. It is starting to happen, but of course it is drowned by the noise of the lingering infectious diseases burden, and now a real threat of NCDs. So we are happy that the NCD message, Katie, thank you, is right up there, but we need to move a step further and show that the cost of inaction is actually higher, so we need to act and at least do something about NCDs.
Thank you, Tim. Your boss is also sort of redefining his mission in terms of, how do we measure progress? Could you share some of that with us and how it is related to what we're discussing around social responsibility and investments of a new type, and actually helping countries like Kenya being able to move forward through new types of financing partnerships, but at the same time, focusing in on what do we actually measure? What's the ultimate success?
Well, Ilona, thank you for that very simple question.
I'm known for my simple questions.
The short answer is yes. My President Jim Kim has been, I think, feels at this stage in his second term as President of the World Bank that the greatest constraint to global health is an apathy and a neglect from heads of state and ministers of finance with respect to the value of investing in people. And he calls this human capital. And it's not only investing in people's health, but it's also investing in their educational opportunity. And he says this not simply because intrinsically health and education are things that are good for people, but instrumentally, societies that have higher stocks of health and education are much more successful at navigating growth in the years ahead. And if we look back and look at inclusive growth over the last 50 years, we see those countries with higher human capital have done better than those countries with lower human capital. So he's developed a measure called the Human Capital Index, and he's really using this as a basis to compare countries' performance with respect to outcomes in health and education, quality-adjusted education years, our learning-adjusted school years, our new metrics that are being combined within this Human Capital Index, but which are then going to be used to rank countries with respect to their performance. And we'll launch this index in Bali at the annual meetings in October 2018. But what it's designed to do primarily is to generate demand. And there's already been a lot of talk about this, and what we've seen is actually there's a lot of interest from countries. And so we're encouraged that even with the focus that the World Bank now defines itself as having 3 primary infrastructure investment areas, one being physical infrastructure, the second being environmental or green infrastructure, and the third being human infrastructure, that this has given a lot more credibility to this area as an investment and not, as it was seen in the past at the bank, as either social overhead or something that countries could only afford once they achieved a certain state of wealth. So that's where we're headed, and I think building demand is great, provided you can respond with respect to supply. And I was struck last night by Adolfo Rubinstein, the Minister of Health of Argentina, when he said on a panel, we need to move from nominal universal health coverage to effective universal health coverage. So not just UHC in name, but UHC in practice. And I think that that's an opportunity to really improve on the promise of building demand and mobilizing more investment, which is actually to go and get very serious about what's involved. And some of the challenges, I think, are really 21st century challenges, because as much as I'd like to celebrate the 70th birthday of the NHS or the 150th birthday of the social insurance system that Bismarck developed in 2 centuries ago, it's not clear that either Bismarck or Beveridge systems are what's needed in the majority of low and middle income countries, where 70 to 80% of the population gain their livelihoods in informal sector activities. And so if you don't have the likelihood of having a fully funded public sector system or a social health insurance as the primary drivers of financing universal health coverage, what does that financing system look like in the 21st century? And might it be a good idea for OECD countries to pay attention? Because if you look at the changing nature of work in OECD countries, we're moving increasingly to the gig economy, and insecurity in employment, short-termism, which is actually changing the whole basis for either the Bismarck system as well as the tax-based system. So there's an opportunity, I think, which is going to require a tremendous amount of investment in innovation and knowledge, driven by values related to UHC, that we really walk the talk on moving from the nominal to effective UHC in the next 50 years.
Thank you. We'll come back to some of those issues, particularly again, you know, in terms of the country level, and hear from Kenya also what model of healthcare you are developing. But we had already heard also from Mariangela at the beginning how important it is to have frameworks. There is a need for normative guidance. There is a need to ensure security of products, to ensure safety of people. And I would like to ask Delese to share with us how this new focus also on the regulation system, how that has developed within Africa and has led to the establishment of of an authority for medicines that would take on such regulatory challenges. Would you share what actually led to that, how the political process was, and what you still need to build and achieve?
So thank you very much, Greg, and for inviting us and all the organizers, and happy birthday to you all. I actually knew I would be the last person to be asked a question, because I always say that the regulator always comes in at the very end, so I'm not surprised. So I'll give you a picture of Africa in general. So we are a continent where there's an increase in disease burden. So we have all the NCDs, but apart from the NCDs, we also have the neglected tropical diseases also. We have weaker regulatory systems, but then we are fighting counterfeits, we are fighting substandard products, and we're fighting drug abuse. We're fighting actually abuse of prescription medicines. So we have a lot going against us, but this is a continent with very determined people and people determined to make the best of what they have. So what we have done is that gradually we worked separately. So each country worked on their own. We tried to build up our regulatory systems with the support of all the agencies who would help. But we realized that it was actually easier, and also easier on industry, if we wanted to ensure that we had access to the same therapies at the same time. So if other countries in the West had it, Africa also wanted to have it, not 10 years down the line, not 20 years down the line, but at the same time. And for that reason, we had to ensure that we could make those medicines available to our population. And for that reason, we decided, well, it was about time Africa started coming together. So what happened was that in the various regional economic communities, we started building blocks. So you have the SADC, you have the East African Community, you have ECOWAS, and regulators started coming together, trying to harmonize our processes, trying to work together to ensure that we could get access to medicines faster and cheaper and in real time. And from there, having our regional economic blocks, some have gone much way ahead of others. In the West Africa region where I come from, we've just started. So we have the African ECOWAS harmonization. So we've harmonized all our processes. So in each of these communities, it is much easier to get a product registered because you'd be able to register it within a certain number of countries within that region and make access available. West Africa has also started. We're harmonizing all our guidelines. We're harmonizing all our requirements, both for registration and for clinical trials. We had a big boost when the Ebola came in. Ebola shook us all. We had to make access to certain therapies and even clinical trials ready on time. So at that point, we sat up and realized we have to work together a lot more. And now what we have just done at the last, on Saturday, I think it was, we've adopted a treaty where we said that we're going to have an African Medicines Agency, where all the countries will have one regulatory agency who would be able to look, just like the European Medicines Agency, to be able to look at products holistically at the same time and make them available to the whole of Africa. Our governments have been in support of that. In most of the agencies, the heads of the agencies are responsible for that treaty. We have all signed it. Our ministers of health have looked at it and have ratified it. And Africa is ready to ensure that they can also get for their population what they need at the right time and at the right quality. We have regulatory agencies that are at different levels. Some are more advanced than others, some lag behind. And what we are doing is that we're pulling the slightly weaker ones along with us, so that apart from just making medicines available, it is also a capacity building avenue for those weaker regulatory agencies to build them up, so that at the end of the day, they can also be responsible. Regulators sit between industry and the patient. So in the same way that you are responsible for the patients anywhere else, we are also responsible for our patients. And therefore, we have to ensure that we can get the right medicines to them at the right time. So that is where Africa has been at this time. Access is what we intend to do it faster, to do it at a more affordable, in a more affordable way, to ensure that there's equity in access, everybody gets the right medicines and the right quality, and to ensure that we can also monitor the quality of the medicines on our market. So that's where we are so far.
Thanks. How did industry respond?
I think industry was very happy, actually. Yeah, because what it is that So before, if you submitted anything to any African country, you'd have different requirements. But what we've done now is that we're harmonizing our requirements. So it's easy to submit to a certain number of countries with the same guidelines. And then to have, I'm actually the chairperson of what we call the African Vaccines Regulatory Forum, which brings together, at the moment, we have 54 countries. In fact, all the countries in Africa are part of that forum. We have a good governance structure. You can actually ask for, industry can ask for a joint review of a clinical trial or even a joint review of a registration of a medicine. And we all come together and make that available. We have cut down our timelines. So before, where one country would have, you submitted an application to one country, it could take 200 days. Another country could take 5 days. I'm not sure how that happened. And there were varying timelines. But now we have all come to a particular timeline of, say, 60 days, where we say that if you submit an application to us for a clinical trial, within 60 days, you can be sure to have a response. And I think industry is actually happy with the level playing field in all the countries, which makes access to medicines much quicker.
Thank you. Mariangela, can I just ask you to take your WHO hat off for a minute and think back to when you were in Brazil and tell us something about regulatory mechanisms for the Americas, how they function, and how they have worked in a similar way than we have heard here, or have there been more problems?
Yeah, when the colleague from Ghana was speaking, you're having a meeting in my office this afternoon. and I'm always struck by the size of the African continent and the challenges you have with 54 member states and with different legislations and so on. And one of the things that we've been discussing is how the PAHO mechanism, the Pan American Health Organization, evolved over time. And Tim is laughing, he knows a lot about it. But it wasn't an easy process, and I was with the Brazilian government at different levels for 30 years, right? It wasn't an easy process, but it's come to a certain type of arrangement that's actually useful for the region in terms of having a regulatory system that has collaborative procedures and to a certain extent with 6 stronger regulatory agencies across the Americas and PAHO, and that has helped countries not only because of having a more reliable system in the region, but it helped countries to for example, to buy products from PAHO that are actually registered in one of these agencies. So it's a kind of a joint procurement. Today, during the discussion on access to medicines at the World Health Assembly, this was, fair pricing and access to innovation and so on, but the alternatives for countries in joint procurement came like in 27 different statements. And this is only possible if you have some kind of agreement, harmonization across regulatory agencies. So I think the Americas have a good experience in this sense, and WHO has now moved towards a global benchmarking tool for regulatory systems. That's very much inspired in the benchmarking that the Americas were using in the past. So I think we need to strengthen more the cross-regional collaboration, and make this, what's working in some countries could be useful for other countries as well. So and WHO has that role, and that came across strongly today during the discussions as well.
Thank you. If we can just stick to this whole issue of regulation and safety and rights, Katie, I'd like to turn back to the patients again and issues, of patient rights, of patient safety, of patients' access to innovation. We heard from the Admiral that, this whole period from innovation to access is to be shortened, etc. What kind of discussions are you having there with patient groups? What kind of developments in terms of pharmaceutical products for life-saving, for living better with chronic disease would patients like to see? Where do they see hurdles?
I think in the NCD space, a lot of it is about that there's so many opportunities within kind of digital health to actually bring the services and the systems and the treatment to people's houses and people's homes. Given that, you know, NCDs are obviously fairly complex and lifelong conditions, it's all about making it as easy and as simple as possible for people, for patients. And so really kind of, you know, mHealth, digital health being a tool to essentially, it's not an end in itself, but it's essentially a way of ensuring patient empowerment and patient engagement and adherence to treatment and things like that. So I think kind of over, you know, over the next 50 years, I mean, it's clear that digital is going to be a key way of ensuring that, particularly in low middle income countries, we're seeing some kind of leapfrogging in terms of progress. And again, it comes back to the way that we're also designing and shaping policy systems and monitoring around access, and just needing, in the NCD space, I think we're just so far away in terms of actually having meaningful involvement of people living with NCDs front and center, whether we're talking about it from a policy development perspective, a service delivery perspective, or a monitoring perspective. And so really what we're trying to do in the lead up to the high-level meeting is try and get that kind of principle in the government's minds, in policymakers' minds, that, you know, it's all about people living with NCDs front and center of what they're doing.
It didn't answer my question. I did want to, I'd like to push you a little bit on that, because many patient groups are very proactive and say, you know, we want access to, and I'm thinking particularly patient groups in this part of the world, we want access, and Hep C was a very clear example of that, to actually, you know, push the access to new medicines, push the access to very expensive cancer drugs, push the access within systems where it becomes very difficult in terms of financing, then also through the existing insurance systems or National Health Service, etc. So I was just interested to know, to what extent is that a political issue you are discussing within the NCD Alliance, and in what way?
I mean, it's certainly a political issue, and in NCDs you've got, you know, some drugs that have been around for 100 years, and many of them are off patent and cost just, you know, pennies to produce. So the challenge of access in NCDs isn't, you know, you can't really kind of focus in on one part of the ecosystem in a way. You really have to look at it across the board. And, you know, the fact that so many NCD drugs in low middle income countries are pretty cheap, obviously cancer drugs are not, but there's some that are pretty cheap, and yet people still are not having access to those essential medicines and technologies. It really points to the fact that you've got to look across the whole ecosystem. And so in the NCD Alliance, we're very much looking at the fact that, you know, this needs to be a kind of key issue around access and the high-level meeting, and it being a political issue. And the other part of it is, you know, the importance, and the theme of this evening is around partnerships, and the fact that, you know, we in NCDA have always kind of been, you know, front and center of the fact that, you know, you need to work across industry, you need to work across civil society, you need to work across governments. We're not going to get anywhere if we're not talking to industry and, you know, taking a very ideological view. I think you need to be really having that dialogue.
Thank you. Could we get down to the country level again? You know, how are you answering the challenge in Kenya in terms of, you know, developing, expanding the health system, providing UHC access, financing? Who is supporting you in taking that forward? And what key political decisions have been taken?
Okay. Thank you, Ilona. I'll probably start by referring ourselves to the perennial question of political capital. Every time we have meetings, we say, oh, political support is lacking. A few months ago, our president in Kenya highlighted 4 of his big agenda that he wants to be remembered with. And lo and behold, affordable healthcare was one of them. Manufacturing, affordable housing, and you know, he also wanted to do something about food security. All those much of interest to health. And so it really hit us because we cannot hide behind political support anymore. Here is the president saying, just ask me. Now the question is the how, it's not the what. The biggest nightmare we are having now is to what is contained in this package. Team Evans and team have been in Nairobi recently to try and launch, together with IFPMA and the Access Accelerated, a product, because the NCD space is very interesting. We make a lot of noise. One time I was asked by the HIV community, if we give you money, what will you do with it? And we had no answer. So we are here saying, the question is, are we ready to do something with this money? So one of the things we are trying to do is to create a prototype of how would it work to scale. My country has been accused of having so many pilots that it's time we brought to scale some of them. My current minister is saying, no, we will not accept anything that comes if you cannot see the A to the Z. Even as we are starting, we should be able to see the end, not let's start with the pilot and then we scale it. So you've asked a question of how are we doing this? So first and foremost, there's very good political capital now. Domestic financing may improve. I'm hoping we do. We'll move probably NCD financing from 1% of the government budget to 5%, whatever percentage would be a plus. 2, we also want to spend some little money on empowering the individual. I think the biggest nightmare we are having, and it's good that Katie has mentioned it, we have very simple, cheap molecules that the government has availed sometimes in the hospitals. But when you go, there is no linkage between this molecule and the patient. The gap in between here is very interesting in NCDs. The treatment gap sometimes is probably fueled by, of course, access and affordability. But there's also the lack of awareness of the individuals. Malaria, TB, HIV, some of those infectious diseases, because of the nature of the disease, they bring the patient to the hospital anyway. I mean, you cannot stay at home with malaria. Somehow, you will still end up coming because it's painful. You could be walking around with a BP of 200 over 100. You know, when you ask the question here of how many personally have an NCD, I was surprised that we didn't ask the question of how many have been tested recently.
How many have been tested recently?
Yes, so there is a proportion of people who are living with an NCD here who have no idea. And it's actually better here. Down in Africa, the IDF estimated that 60% of the people with diabetes in my country have no idea. And they get to know their status when there is a complication. They now have a stroke. And when you're looking back, oh, why would a 50-year-old have a stroke? We realize, oh, you've been living with hypertension or you've been living with diabetes. The question is, how do we create demand? Because in as much as we improve the health system, the patient has to realize that, oh my, I need to go and access this healthcare. And so we are first and foremost prioritizing partnerships because some of those regions are not the strengths of government. We are not as strong in empowering the patients and education. So we partner with patients associations. We partner with the youth associations, with community health organizations that have, you know, access to the patient and the people more than we do at a government level. So then we are also, my country has devolved healthcare so that some decisions, major decisions are made at the local level. So, but the people who are making those decisions sometimes are not very well capacity built to make decisions that probably would be sustainable. So we are having several pronged approaches. One is to empower the patient. 2 is to build the capacity of the decision makers down as we cascade very technical issues. We want to reduce the distance the patient has to travel with an NCD. It's unacceptable that you have hypertension and has to travel from the village to Nairobi. You can get your diagnosis, yes, but the refill of antihypertensives, it doesn't have to cost you a journey. So for the country, we are having to reorient the entire health system because it was built on an infectious diseases platform. Now, infectious diseases platform are very brief contact with the healthcare. You come, get your 3-day, 4-day malaria treatment, and that's it. But for the NCD platform, it's a long engagement with the health system. And the patient sometimes along the way gets tired. They are the most gullible. Sometimes they decide to try traditional medicine. Sometimes they stop along the way. So the outcome is very poor, not because sometimes it's an access thing, but it's because of the patient. Now, at the same time, we have platforms that we have not utilized fully. For example, the mobile penetration in my country is very good. It's almost 80%. But we have not invested in that to try and use it for patient support. The other thing that I would talk about is the patient themselves are the ones who know their disease better than we do. I read diabetes in the books. My mom is diabetic, and she knows diabetes more than you should see us arguing. She has her own way of what she knows about diabetes. But I understand that she knows the social part of diabetes better than I do. I have no idea how it feels to be 1 week without treatment. I know it is bad, but she knows it personally. So I think we are also investing in patients' support groups, in the individuals themselves, because it's a space that we have neglected. And finally, the issues about partnerships, if I may just talk about them, because pharma has, the last 50 years, has seen a lot of changes. If somebody was born when IFPMA was formed, the kind of relationship that the Ministry of Health and the pharma had and the one that we have today are totally different. Along the way, we became strange bedfellows with the pharmaceutical industry. I don't know where that happened, Thomas. But we are realizing that we cannot do without partnering with the pharmaceutical industry. At one time, we call you big pharma. We see, oh, these guys are just here for profit, and But I think that is changing because we have realized that there can be a win-win. In actual sense, and I'm happy that Dr. Tedros says that fence is not a fence. For sure it is not. The question is not whether we should engage. The question is how do we engage? Because there can be a very open way of engaging with regulatory authorities there to, midwife the process. And there can be objectives that you have and we have, and the patient benefits along the way. So we are experimenting with partnering with pharma. We have burnt our fingers once in a while. But I think there's a lot of benefit, especially for the patient, when the government decides to sit down and negotiate. Prices come down. Pharma is interested upstream. In the past, pharma is only interested downstream where the molecule meets the patient. But now you'll find pharmaceuticals that are interested in prevention, upstream where you would think they're shooting their own foot. So it's very interesting to look at that space, and we're investing in that innovatively, and I'm hoping that we will reap big in that space.
Thank you. Mariangela, has pharma changed?
Which pharma?
There you go.
Actually, we're talking about a very heterogeneous group, right, Thomas? And you have companies that are much more forward-looking and more open to partnerships, and companies that are not so advanced. I think that's also related to generics and to the innovators industry. So I think times have changed because science has changed and demand creation is changing as well. But I think we are seeing some progress. But I want to see actually people having access to the technologies they need when they need it. So I think John gave some good examples.
From your perspective, and then I'll ask you to put 2 or 3 questions to the panel. You've quite a career through Global Health, Tim, in various organizations. You've negotiated, with a whole range of stakeholders in that work. How has partnership changed in global health?
Well, I think we've moved from global health being some sort of charitable, missionary-driven thing that lost individuals did in their spare time or after they retired, to being a major force for civilization in the 21st century, which has got a massive demand coming up, most encouragingly from young people. If you look at post-secondary education now and look at demand of students in terms of what they want to learn, every course in global health is oversubscribed. And I think what this represents is that the value of ensuring everybody has access to the services they need, that children born everywhere have an equal opportunity of survival, that nobody with a chronic disease is limited from an opportunity to live with that chronic disease, given that there is available effective medicine. I think that value is uniting. And I've seen a really encouraging transformation from, if you came to the World Health Assembly as I did back in 1949, no, not quite that old, but you would not have seen it be the epicenter of incredible initiatives and activities. If you'd said $1 billion back in 1999, as we did with respect to Gavi, people thought we had a DSM-4 delusional disorder, right? And then, you know, within 5 years, there were $6 billion funds, right? And I think what we've seen is that the legitimacy of thinking about the globe's health has come to the mainstream. And with that, a massive surge of initiative, talent, and opportunity. So I see it very optimistically. And I think that we're so much better off as a global community. And I would argue, as an economist who studies the ripple effects or externalities of movements, global health has had a tremendously civilizing force for humanity in the 21st century. It's something that brings us together rather than takes us apart. And that's not to underestimate any of the issues related to the disparities that exist, but there's consensus or growing consensus that those disparities are unacceptable. And what we see is mobilization on multiple fronts, and including from the industry. The industry, to get them to focus on the globe back in the 1990s was very difficult. You hear pharma CEOs now taking the big picture view. Why? To me, it's not rocket science as an economist. Would I want to develop a market for 7 billion or 1 billion? I think I'd go 7 billion, even if that meant margins are lower, right? And I think there's a realization in 2050 or 2100, when there are 4 billion Africans, and in fact they're majority shareholders in the global pharma industry, don't you think that's going to have an impact on what the priorities of pharma are? And so these are things, these are shifts, I think, that are going to be incredibly positive and ones which make me feel like we're moving in the right direction, the challenges notwithstanding. One challenge that I would like to say is we are in this period of absolutely romantic infatuation with anything digital. I mean, you say digital and people say yes, right? And it's not that I'm a naysayer. I do it too. I love it. I just don't understand any of it, but I think it's great. But I think back before we had regulation of the pharmaceutical industry and standards for evaluating what is the value added of the latest potion. And I think we've got to move from digital alchemy to a new set of regulations that are really going to give some real sense of what the value added of some of these things are. And I think this is an industrial opportunity because there's such a mushrooming of experimentation and new ideas. But it will have to come under some discipline, and I think that's the next frontier, which is going to be tremendously exciting moving forward.
Thank you. I think we're very tight on time now because we also started this panel very late. So I'll just ask each of the panelists to give us one final comment. We've heard this very optimistic, forward-looking vision that Tim gave us, and I was nearly close to saying, yes, here is a closing word. But I do think I'd like each of you to say, where do you think is this principal common agenda that we should be addressing together? Where do you see the most optimism to move forward together? What point would you raise? Mariangela, would you start?
With optimism. I'm an optimistic person. But I'm going to frame it as a challenge because I think we have, at the same time, I'm optimistic about making technologies that are already available, you know, that they should be, people should have access to them, and especially the NCDs, a lot of the drugs or the assistive technologies, they should be affordable, and they are already available. But I see that the new frontier that we will face in the next years is how do we manage the innovation that's coming with the biologicals and the biosimilars, and the benefits that they may bring to humanity, and how do we jointly address the access issues around these new technologies that can change. They will be a game changer, I think, for the next 10 years. I'm looking at it from a positive perspective, but we will need to work hard on it.
Delese, from your perspective, what would you pick up?
I'd probably say collaboration, early engagement, and communication. I was in a meeting about 3 weeks ago where it was a product development challenge meeting that was organized by one of the funders. And I looked around and I was sitting amongst a group of researchers. And 10 years ago, this wouldn't have happened. So it would have been them over there, we over here. When they're done, they come to us, and then there's a delay. So for us as regulators and regulators in Africa, what we would say is engage us early. Collaborate, we are collaborating amongst ourselves, and let's communicate, because that is the only way we can get the medicines out there faster. The more we work together, industry, research, and regulation, the quicker we have access, or we can give access to new therapies to our populations and to our world quicker. So regulators should not be engaged at the end of the process, but they should be engaged right at the beginning, and there should be constant communication between regulators and industry.
Thank you. Katie, I guess you'd say the same thing for civil society organizations.
Well, it's quite nice actually being on this panel and not being the last person to speak as civil society, so thank you, Ilona. I would add on Delese's points around, I think what's kind of optimistic and exciting in the NCD space is actually just the fact that civil society is impatient and frustrated, which is obviously a signal of the fact that there has been this lack of progress, but it just feels like there's a new sense of urgency from civil society. And as Sir George Lane always says, the importance of agitating, advocating, and educating, so to build on Delese. But one just final kind of caveat on these discussions around partnerships that I think is really important to make, and it's not so relevant for IFPMA and these discussions, but I would love to see Dr. Tedros talking about partnerships, but making a really strong caveat for the fact that there are certain industries out there from an NCD perspective that are really, really difficult. It's the good, the bad, and the ugly of the private sector for NCDs. And we can't be talking about partnerships as a whole for global health. We need to be really careful with big tobacco, big food, big alcohol.
Thank you. Tim?
I think you've heard enough from me, but, and unlike civil society, I'm an uncivil banker. But I do think in terms of things that are particularly important moving forward, I think one has to balance what I call global health without walls, which is just a tremendous opportunity to understand and direct and redirect energies to outstanding needs, but also to achieve scale efficiencies that can only be achieved through collaboration and cooperation, which is very much the science and knowledge and new technologies agenda, and balance that tremendous force with attention to the individual that lives in the most difficult and disadvantaged circumstances, and ask the question, how are 21st century health systems helping that individual?
Thank you. Kibachio, is that the question you would put?
Yes, I would, and I would look at how do we consolidate the gains. This meeting has celebrated gains over the last 50 years, and I'm afraid we need to focus on how do we consolidate the gains. I'm one stickler of integrated healthcare models. And why I say that is over the last 50 years, we have seen immense investment into, for example, let's use the HIV model. I currently in our division have what we are calling the fourth 90. The UNAIDS 90-90-90, that we identify the 90% of the patients, put 90% of them on treatment, and achieve 90% of viral suppression. We are saying the story does not end there. it's amazing how you change the life of a person from an acute illness to a chronic illness, only for them to die of renal failure, for them to die of hypertension, for them to die of diabetes. It's a waste of the efforts that we have done on the HIV story. So we are also moving that, hey, 90% of those guys should have access to essential NCD treatment and mental health care. I mean, it only makes sense. And it does not, the incremental cost is not as the same as starting afresh. So the same platform that has been laid out by the HIV platform, PEPFAR has funded labs, nutrition programs. So we're just asking to loosen a little the rules so that we can leverage NCDs on that platform so that even it works better for the HIV patient. So my message would be more of an integrated care of approach. And anyway, it is in line with the SDGs because the SDGs took a wellness platform. It did not take an illness platform like the MDGs. You know, the African governments just judged themselves on the 3 MDGs that are talking about children, women, HIV, and AIDS, and they thought they've done everything. This one was a wellness opportunity. And so I would say integrated care, and to borrow from a team, is you are not healthy until your neighbor is also healthy. So that would be the message that I would throw ahead. 50 years going forth, Thomas, I think I would want to judge you on how much health you inject into the globe rather than how many diseases you're treating.
Thank you. Thomas will look down from above in 50 years' time, but hopefully very benevolently, and hopefully when those people who will be here celebrating 50 years from now, they'll be able to look back and say, those guys really made a difference. Those guys put us on the right path, and those guys laid the basis that we would not lose the gains that we have made, but actually are able to multiply them. Thank you very much. Thanks to this fantastic panel. Thanks to the audience. And thank you and happy birthday, IFPMA.
Thank you to the moderator. That's the first time. We want jelly now.
Why is the jelly?
So I will keep this very brief, but I wanted to thank all of the speakers for their wonderful interventions. The discussion tonight and throughout the World Health Assembly underscores our common purpose to promote health and well-being for all. I think with today we mark IFPMA's 50th anniversary by committing to doing more and doing better together. And again, this discussion gives us a lot of food for thought, but this is only the beginning. And I'd just like to thank all of you for joining and to say, bring on the jelly.